everyone. I am excited to be here with you and doing something of a virtual roundtable. So I've got an abbreviated version of some content that we would have covered if we were able to meet in person for this APP meeting, and want to spend just a little bit of time talking through these slides and kind of framing up this concept about our understanding of first-line care and how it is how we're doing really as a healthcare provider community in meeting women's needs in this context. So if we've not met or kind of had a video introduction before, my name is Jessica McKinney. I am a physical therapist. I'm based in the Boston area working with Renovia, heading up a department called Medical Affairs and Clinical Advocacy. I came into Renovia from a background of working as a community-based physical therapist, primarily focused on women's health and urogynecology, and working very closely with the urogynecology community here in the greater Boston area. And I've been with Renovia for about 2.5 years. So what we're going to cover here in this roundtable will be just kind of the background of the care pathway for urinary incontinence for women, and then dealing with a couple of the questions that tend to come up when we are thinking about whether that care pathway is something that only looks great on paper or if it's actually being carried out. And you see these questions highlighted here. So what are the different elements? Does pelvic floor muscle training work, given that it's one of the components? And then what are some of the factors that influence pelvic floor muscle training? And then we're going to look about whether HCPs are actually following the care pathway. And then the last little bit will be just a bit of sharing on what Renovia as a team is doing as one way to try to help bolster care in first line. So the backdrop for this is that female urinary incontinence is a really prevalent health condition, burdensome, and affects such enormous numbers of women. So our conservative estimates are that about 20 million women in the United States have urinary incontinence, and that only a quarter of those are care seeking. So a fraction really are the ones that are ending up in our offices, in our practices, and that the majority, about 3/4, are maybe in the healthcare system but are not seeking any care for this condition specifically. And there are several factors that are going to be driving the size of this as a population and the number of those that would be falling into the care-seeking population. So among those are the fact that urinary incontinence becomes more prevalent and more problematic generally with increasing age, and we have just in absolute numbers a growing aging demographic. Right, so that is going to be one thing that makes these numbers grow substantially in coming years. But there's been some movement in terms of screening guidelines being developed for screening proactively women. So of this 15 million that we see below the water of the iceberg, doing some things to screen those women to bring them above the waterline and into the care pathway if that's warranted. And we're going to talk a little bit about those on the next few slides. But it means it's a really interesting time for us to be in the space where we are and really trying to push ourselves to figure out where can we innovate in terms of all aspects of our care delivery so that we can meet the healthcare needs of more women. Limited and delayed care seeking is well documented in our space. And as we saw in the previous slide, that it's only a quarter of women who are actively bringing this up. And there are a lot of factors that go into it, but there is a substantial knowledge deficit in that, women often don't know what are the avenues for treatment, and they may think that surgery is their only option. And so they have self-selected, maybe they've decided that is not for me. And whether that's fear-based or, their other obligations. And so they don't bring it up at all. And a lot of people also remain uncomfortable with the idea and would prefer that their healthcare provider raise the question to them. And they also have a hard time contextualizing it as a health condition, but like feeling like it's enough of a problem that it warrants medical attention. So with some of that in mind, there was a major initiative from the Women's Preventative Services Initiative, as it is called, but they really set about to ask, is urinary incontinence a health condition that really warrants a widespread screening? So I would encourage anyone who's interested to pull this review on screening for urinary incontinence in women. They had a couple publications that came out of this multi-year effort that was headed by ACOG, but had several partnering organizations as partners in this work. But their main conclusion was that, here we have that annual screening really becomes recommended for all women starting in adolescence. Like that is the headline that came out of the work, in that it is so prevalent that there are screening tools available, and that it is worthwhile. And furthermore, that even at the primary care level and at the OBGYN level, that they can begin first-line care, so that they can be the ones to do the screening and initiate first-line care, so including pelvic floor muscle training for women, and that they really concluded that that was a strong recommendation from the American Academy of Family Physicians. So this is just a bit of a screenshot of their well woman care chart. And I have highlighted here that they have named urinary incontinence screening. So any of us who are women who have had well women exams, you're familiar with several of these other elements. I mean, there's screening for alcohol and counseling if appropriate, blood pressure screening. So added to those things is the screening for urinary incontinence as a recommendation. Part of the work of this group was a systematic review to identify what are the best screening tools to determine the presence or severity of urinary incontinence. So they looked at a host of tools to try to figure out which were the most reliable, which might be the best to use or to recommend. And this slide highlights 3 that were highly rated, and you glean different information from each of them, but they are 3 that could be commonly used in practice. So the 3IQ, it's a 3-question incontinence questionnaire that looks to ascertain both the presence, so yes, no to incontinence, and then give a provisional diagnosis, so what is the type. The BSAQ, so the bladder control self-assessment questionnaire, is one designed for males or females, and is designed to identify, again, presence of incontinence, as well as a quantification on the bother of UI symptoms. And then they have a graph at the bottom, or a table at the bottom, that can be used to even guide some conversations around directing care, so that if someone scores above a certain threshold, that is indicative of someone who might benefit from starting to get care for their urinary incontinence. And then another that was the highest rated is the Michigan Incontinence Symptom Index, the MISI, that is, again, type and bother of incontinence, but also sensitive to change. So this is one that could be designed or could be used for documenting some change over time. So for practices who are looking for something that would double as a screening tool and a way for them to revisit that tool to document change over time, the MISI might be useful. So that's the backdrop for kind of what's going on in our world. And it's that there are several professional bodies and publications, all of which are driving this idea that more women need to be screened. So for those of us that are involved in the care of these women once they've been diagnosed with incontinence, we need to be aware of that, because that should mean that over time, even more people are coming in our doors, are turning to us. So this is probably familiar to everybody that's listening, but just to highlight, what are the elements of the care pathway? The key part on this screen is that, when we look at urinary incontinence in women, pelvic floor muscle training, that's like really the space where Renovia and our company is sitting, that is accepted and established as the first line intervention for all of the major subtypes of urinary incontinence. So when we're wondering, what do we do out of the gate for somebody newly diagnosed with stress incontinence, mixed, or urgency, pelvic floor muscle training is one of the things that can be started really for everyone. And if you've heard our other lecture, I like to kind of level set on some terminology. And one is, what is first-line treatment? So this is a definition not specific to urogynecology or women's health, but it is really something that has been identified for any health condition, for any disease, that is what we believe is going to be preferred best first treatment. And it's looking at it as a combination of both efficacy, safety profile, and or cost. So what we're saying here is that the things that fall in first line in the space of treating female urinary incontinence includes pelvic floor muscle training. And it's for these reasons. Not to say that that is going to be all that anyone needs, but that when we balance safety, cost, and efficacy, it's a great place to start. Which begs the question of, does it work? So it's another thing. We've heard lots of people who say, oh, well, no, I already tried my Kegels and it didn't work for me. And that really is the essence of why this talk has the title that it has. Any of us that have been involved in the care of women with incontinence know that we've had people come to us and like, oh, I've tried that before. I've tried Kegels, I've done them and it doesn't work for me. And there begs the question of, well, what was done, right? Like, were you actually on a program of pelvic floor muscle training? Did it have some element of supervision? Or did you go home and kind of arbitrarily do whatever you thought maybe you should do? Did you follow just a written sheet of instructions? And so it's really, the title of this is to cause us to examine some of our own behaviors, but really, like, as we extend out into our spheres of influence, how are we talking to other people about pelvic floor muscle training, and what is consistent with saying, okay, you actually really did. You did a great job at trying first line and it didn't work for you. And now it's time to move on, versus you really kind of did it in a 25% capacity way. And maybe we should revisit it and know that we have done a great job, done a solid effort at first line before deciding to move on. So this slide appears in another one that we've had here, but it's just a chance to kind of revisit this idea that pelvic floor muscle training is repeated and voluntary pelvic floor muscle contractions taught and supervised by a healthcare professional. Generally speaking, that is the definition that we're looking at. Stress urinary incontinence demonstrates cure rates up to 56%, mixed incontinence of 25%, with improvements coming over 6 and 12 months. So there is incremental progress as people continue to be consistent in their programs. Some studies are going to report much higher cure rates or rates of improvement. Part of that is going to be in the definition. This particular review is looking at cure as 100% dry. And there are other studies for whom what's reported as success, treatment success, doesn't necessarily mean completely dry, completely continent. And that's okay. It's just a matter of definition, and important for us to frame that up as we make decisions about these numbers and saying, gosh, I saw another study and it said 35%, or I saw another study and it said 77%. It's just trying to tease that out. This is one review, brought together a lot of data. And I think it's a nice idea of a set point for us. We've said here that the first line treatment recommendations for pelvic floor muscle training are, happens at the first line. It's approximately 12 weeks in length, or at least 12 weeks before we can say that it's done, and with a skilled healthcare professional. The next bullet, though, on this slide is important, that we still lack consensus. So we have consensus really around this first bullet and not consensus around the second in terms of the frequency and duration of supervision. So supervision doesn't necessarily mean a weekly follow-up or a twice weekly follow-up or bi-weekly follow-ups. That is still out to jury. The background and the training of the supervisor, there's not consensus on that, as well as some of the different parameters of exercise in this context. So there is wide variety in terms of the recommendations of maximal versus submaximal contractions, the position that the body is in, how many repetitions, sets, and the other parameters of the exercise program design. So that brings us to question number 3 in this context. So if the last one was, does it work? And we tell ourselves, we finished that and said, well, yes, we have enough to tell us that it works. We need to make sure now that we carry it out. We believe that it works and we want to carry it out. We need to think about adherence, because this is not something we can do to other people, right? We need them to be participatory in the program. And so we want to look at a little bit of the information around what are the drivers for keeping people motivated and engaged in a program of pelvic floor muscle training. Again, for us to feel like we've we, the collective we've done a good job. We feel like we're satisfied. We made a good effort at this execution of first line. And we need to study this because, 3/4 of women who have pelvic floor disorders report that they don't on their own regularly perform pelvic floor muscle exercises. That's one interesting finding. And then another is the series of 4 papers that came from a committee at the International Continence Society that were really specific to pelvic floor muscle training adherence. They recognized that adherence is a key factor and set out to examine all of the literature and come back with some recommendations on that. And so that is a series of papers I would highly recommend for anyone to read. What you see on these next few slides is just such a snapshot of the richness of what they published. But one of the things that was guiding this was that to adopt a program of pelvic floor muscle training requires health behavior change, right? It says, there's something that I have not been doing, and I need to start doing that for the sake of my health, and I have to make a change in my behaviors and my habits in order to achieve this health outcome that's desired. So there are several different models of health behavior change. And so some of them have been studied in the context of promoting adherence to pelvic floor muscle training programs. And so then we kind of think about, well, why do we apply this to pelvic floor muscle training programs specifically? And the evidence that exists so far in health behavior change theory, generally speaking, is that outcomes can change when we pay attention to the things that motivate and sustain health behavior change. That makes sense. And so, the ICS group gave us some guidelines that we can look at, and in our study of that and in our desire to really help support our patients to achieve the outcomes they need. So some of the modifiers here are highlighted, and they are knowledge. So what is somebody's baseline knowledge of their understanding of the pelvic floor? How many people have you ever heard say, what, I have muscles down there? Or I don't understand how that is related to my leakage. So making sure that our educational techniques are and content delivers valuable and then actionable knowledge to the women we're working with is really important. The physical skill is important. So they need to know and understand why it is that they are being asked to do these series of exercises. They have to then have a way to cultivate the physical skill of being able to do the exercises. And this is where biofeedback specifically can be a bit of a help for people, so that they are affirmed or they are provided feedback that lets them know they need to change what they're doing and try to strive for something that's better. Additionally, it's looking at their feelings. Pelvic floor muscle training has often been, called less than the most exciting thing to do. And so there's not this innate reward. It's not the sense of, well, I do it and then I look this certain way. And so, having this sense of dissecting what are the people's feelings about it, how do they feel is success, what does success look like for them, can be useful conversations to have. Additional modifiers were the ability to analyze and plan for what they were doing. And this is really key. Look, this first bullet, that their symptoms and the severity of their incontinence is not necessarily predictive of adherence. It is a really easy leap, I have felt, for people to make, to think, well, the people who have worse incontinence are going to be the ones that are more adherent to programs or more interested in care seeking. And that's not always the case. And so here, this sense of, and the next one is, do they believe that this is a worthwhile endeavor? So how are we talking to our patients about what we're asking them to do in a way that supports this idea that this really is worth the effort? And recognizing that this is not a one and done, right? I mean, all of us wish we could find quick fixes, but this is something that requires them to show up and to keep paying attention and to do it habitually. I've heard it joked a little bit more like the important habits of brushing our teeth and dental hygiene, that at least for a period of time, to get to the dosing, to get the therapeutic outcomes that are desired, it just requires showing up. And so it can be helpful to, to figure out how we set the priorities around what we're going to do, when are we going to plan to do it, and we as the healthcare provider can help with that. And so here prioritization comes up with it. There's a lot of conflict for people around prioritizing anything to do with their own health, particularly when they're in a caregiving role for others, and balancing the competing priorities of the other things that are important for them to do, the other responsibilities that they have, with the need to then fit in this other thing. And so it very often results in people kind of doing it. Well, yeah, I kind of did it. Oh, then I kind of forgot that day. Instead of, really being regimented and saying, I'm going to stick to it for this period of time. And then the last is service provision. So, how much care costs, and where it is, how easy or difficult it is to get to appointments, can influence positively or negatively adherence, as well as the degree of supervision that they're able to have. So, there are many of us are making a lot of pivots toward telemedicine, telehealth-based interactions. And so this is one way that we may be helped. We may be able to see that enables us to provide some type of supervision that is much more accessible for our patients, and hopefully a meaningful driver of good outcomes. So, here, this just summarizes some of the clinical recommendations that this group had for adherence, and we've covered a lot of these. Don't underestimate the importance of the education, thinking through how we're educating women, and they're at different levels, but educating so that they understand, dealing with the physical skill of performing pelvic floor muscle exercises, their feelings about the training program itself, planning how they incorporate the exercises in this new ask, and figuring out how to jointly prioritize the pelvic floor muscle training in their lives. So this next one, Q4, the fourth question is, we have all this great evidence that has helped us build these beautifully laid out care pathways. And we can spend a lot of time talking about what we do at each step of those care pathways, but we are stymied in all of our goals to have that be really useful, based on how well we as the healthcare community are carrying those out. So I will say, just as a blanket statement, these are better studied, at least the execution of this is better studied outside of the US, particularly in Europe, than it is in the US. So I have two slides to share with you that are on some European data, and then I'll tell you about some findings we have in the US. So the NHS is in the UK. This is a large cohort. Like you see, it's over 7,800 women broken down into a younger versus an older demographic. And the degree to which conservative treatment, so that is education, biofeedback, bladder retraining, lifestyle management, so all of those fall into first line, and you can see that they are also very incremental to each other, was provided for 68% of younger and 61% of older women when they were seen at the hospital. And those who were seen in primary care, there was a significant difference, with fewer older women getting routed to conservative care. But again, this is over 50%, and in many cases about 2/3 of women who saw the healthcare provider and were started with conservative treatment. And these were findings from 2011. There was a survey then that was done of general practitioners in the Netherlands, asking them about adherence to professional guidelines. So there they have national guidelines that say women should be screened for incontinence. They need to start with conservative care, which includes all of those same things that we identified previously. And over 80% reported that they were referring women to conservative care. And that, kind of the net of those two studies was still a statement by authors that they could do better. They were like, we're still not getting everybody. We need to do a better job. And I just have to really commend them, because we would be doing well in the US, if we could say that that was the case. This is some work that our team did in combination with a health economics and outcomes research based firm. And it was, I think this says it's unpublished, but we were just on the verge of it. We will have 3 manuscripts that emerge from these findings. But we looked at a population of women in the United States. So we were able to use an insurance database and identified over 100,000 women with a diagnosis of stress or mixed urinary incontinence. And disappointingly, I'll say, 4% of them had documented non-pharmacologic care as the first thing. 61% had medication, so pharmacologic care. And you can see there's a sizable percentage where the records we looked at show nothing in the 2 years following their diagnosis that was an intervention for their symptoms. So this is it's really low numbers. I know from closer look at these numbers that we have only 1.8% of these had physical therapy appointments as the first stop, and only 2.6% of this entire group, right, of 103,000 women, almost 104,000 women, had any physical therapy at all that was tied to their urinary incontinence in the 2 years following their diagnosis. So what I take from this, and I know I've seen some other literature that, there was an abstract that was presented at SUFU that was really looking more at progression to third line for women with urgency incontinence, and still documented almost identical findings of 5% of women going to first line care as their first stop, and getting it out of the total group that they looked at. So I think that, if you take any of this away, it's that it's possible to do more, but we are really, really far off the mark here in the United States. And so, I think that we need to look for a lot of different strategies for how we can help bolster the beginning of that, that funnel, the beginning of that care journey for women. So the last points that I want to make here are just a little bit about what Renovia specifically is trying to do. This is just what our team is doing, right? Like, all of you are active in this in your own ways. I've been active in my own way in ways that are completely different to this, over the course of my career. So I just want to offer this idea. This is one way that we're kind of looking at how do we monitor first line care? How do we scale first line care, right? If we've only got 4% of women in a 100,000 plus cohort that are getting it, what else do we need to do? So one of the things that our group is doing is through the design of our digital therapeutic, we are collecting data on utilization. So we have a device that is used to collect data about pelvic floor muscle movement in response to pelvic floor muscle contractions, has people on a training program, and the data from that is captured and reflected as a week-over-week comparison of their adherence and utilization of it, as well as the collection of various patient-reported outcome measures. So the UDI-6, the Urogenital Distress Inventory, is a 6-point standardized and validated questionnaire embedded within the app that women are completing on regular intervals. We're also collecting information on patient global impressions of severity and of improvement, and reflecting all of that back into reports that are being distributed to referring healthcare providers. So that could be any of you. If you are seeing someone at various intervals in a telehealth construct, or in face-to-face, that these are reports available to kind of bolster that sense of giving the HCP even more data to go on to drive those conversations around the value of the first line care as the therapy. This is a way of highlighting just what we're doing in terms of mechanism of action. So, one of the other things that we're doing is providing a sensor or unique sensors that are providing emotion-based feedback on veracity of pelvic floor muscle action. So what is interpreted as the correct motion is going to be movement that is kind of toward the left of the screen as you're looking at it. It's in an upward direction. It's consistent with the lifting and squeezing motion of the levator ani. So that is interpreted as doing the exercise correctly. That helps with the mastery, the physical mastery of the skill, and provides them that information as they're using the device. If you've got some more questions on the mechanism of action, I'd invite you to watch our other webinar that is more the hands-on experience. But essentially we have 6 small motion sensors that detect movement and their position relative to the surface of the earth. And it is because of that that we're able to have a composite image that reflects real-time location intravaginally. So that is at rest and then in response to muscle contraction. And then the last piece here is, again, what have we done with this idea that we want to support effective therapies, effective access to care for women in the first line, and so have taken the evidence that we've talked about today and that elsewhere, and have also done our own study of the development of this app and of the physical device to enhance the therapeutic experience for women, so that we have an improved onboarding sequence, so that it is easier to use, that we're bringing those barriers down. We talked about embedding a clinical survey, so that is there. There's a voiding diary included, and they can set reminders. So one of the biggest things that is in adherence is like, I forget to do my exercises. So reminders can be set to perform them twice daily, different times of day, days of the week, and then visuals and scores that are easy for women to interpret. So that is a brief overview of what we would have discussed over coffee and breakfast if we've been able to meet in person. But I hope that gives you a little bit more context about really on all the front end, what are we thinking about in terms of the integrity of our language as we're thinking about first line care, and have people done it, and how are we showing up to support individuals in that process, and even larger, our practices and our institutions, in terms of figuring out how we might be able to leverage any of those resources that are at our disposal to improve the therapeutic process and outcome itself, as well as the access to being on that in the first place. So thanks for your attention. I will make sure, if you haven't picked it up somewhere already, that you have my information. If you'd like to reach out, I'm very happy to be in touch, to answer any additional questions that you may have about anything that we've covered here. And I hope that you enjoy the conference. Thanks.